Hi, my name is Kendall Knuth, and I am a CSDE Applied Epidemiology Fellow working with the North Carolina Division of Public Health's Injury and Violence Prevention Branch. Today, I'm presenting on alcohol's involvement in suicide using 10 years of NC-VDRS data. In 2018, there were 4,084 deaths attributable to excessive alcohol consumption in North Carolina. Excessive alcohol consumption is defined as binge drinking, 4 or more drinks in one sitting for women or 5 or more for men. Heavy drinking, so 8 or more drinks in 1 week for women or 15 or more for men. Or any alcohol consumption by pregnant women or people under 21. Excessive alcohol consumption has immediate health risks, such as motor vehicle crashes or falls, and longer-term health risks, like liver disease and certain cancers. It also results in more than $7 billion in economic costs per year. The same year, 1,463 North Carolinians died by suicide. This is about 4 suicides per day and accounts for almost 2/3 of all violent deaths. Excessive alcohol use is a known risk factor for a number of injuries, including intentional self-harm. From 2009 to 2018, there was a 26% increase in the number of suicides and a 47% increase in the number of deaths attributable to excessive alcohol consumption. During this time, almost 1/3 of suicide cases tested positive for alcohol. To better understand the relationship between alcohol and suicide in North Carolina, we build from a study done by partners in Colorado, though we diverged in a few ways. While they used the U.S. standard 0.08 cutoff for alcohol involvement, we used the National Transportation Safety Board's recommended 0.05 BAC cutoff, as they've shown impairment occurring at this lower level. We also added a few more subgroups for analysis. In this study, we used the North Carolina Violent Death Reporting System, NC-VDRS, data to determine demographic data, mechanism of suicide, blood alcohol content, and circumstance information. We limited to suicide decedents who were North Carolina residents and at least 10 years old at their time of death. Statistical significance was assessed using chi-square tests. Of the 13,101 total suicides in our 2009 to 2018 time period, 88% of them had alcohol tests performed. Of those cases with complete alcohol toxicology, alcohol was present in 30%, or 3,448 deaths. Among these cases with alcohol present, 85% of cases had a blood alcohol content of 0.05 or greater. The largest percentage of decedents had a BAC between 0.08 and 0.16. 15% of cases had a BAC below 0.05. We also examined demographic data. Men represent 76% of suicide decedents, but 80% of decedents with alcohol present. 35 to 44-year-olds represent 17% of suicide decedents, but 21% of decedents with alcohol present. Rates were consistent across race and ethnicity. VDRS provides rich circumstance information, and the circumstances of suicide differ by blood alcohol content level. Those with a BAC of 0.05 or greater were more likely to have an alcohol problem, an intimate partner problem, a recent crisis, or have disclosed intent to die by suicide. Those with no alcohol present in toxicology were more likely to have left a suicide note, have a current mental health or substance use problem, or have a physical health problem. Those with a BAC of 0.05 or greater were also significantly more likely to have an argument preceding death, another substance problem, a job problem, or criminal legal problem when compared with cases with no alcohol present. Overall, 30% of suicide decedents tested positive for alcohol during our 10-year study period. 85% had a BAC level of 0.05 or greater, the NTSB recommendation, and 75% had a BAC level of 0.08 or greater, the current U.S. standard. Numerous circumstances were more likely to be present in a death where alcohol was present. In light, we recognize that the risk for alcohol-involved suicide occurs at levels below what is recognized as the legal limit of impairment. Research indicates that population-level alcohol prevention strategies, including stronger alcohol policies, could be effective at preventing alcohol-involved suicide deaths. Effective alcohol policies to reduce excessive alcohol consumption may include the regulation of alcohol outlet density, maintaining limits on days or hours of alcohol sales, or commercial host liability laws. A more complete understanding of the role of alcohol as a risk factor in suicide deaths will support communities in developing comprehensive suicide prevention programs that address excessive drinking and its harms as well. Thank you for your time, and please feel free to reach out with any questions.